So I've kept you for 35 minutes, and I
Harold,
promise.
always a pleasure.
So thank you
So we
so
can talk
much.
about, keep going.
So maybe we can spend a few minutes so that you can say hello to my students. And I have um, so I'm teaching a course in medical cost effectiveness that some of which would look quite familiar to you, given what you and I did together years ago. Um, and so we did. We're doing willingness to pay for equality and a bunch of issues of that nature. And some of my students are asking, what is the payoff to all this stuff? So there's this whole literature on having to define, having to do cost utility analyses of various interventions and trying to figure out social willingness to pay for equality and so on. Are there any actual policy decisions being made using these techniques that you see in the world that you live in?
I, I guess my view is that I have not seen situations that are very explicit between the cost per quality is $65,000, therefore we're not covering it, or we are covering it. Although you do see that in other countries. The UK is somewhat known for that with their institute called NICE, the National Institute for Clinical Excellence. In the US, we don't operate in such a direct manner, although I think that the evidence that's produced by these types of studies um, help inform the debate in general about where there is waste and where there's not waste. And so as we begin to think about particular services broadly, and as physicians face more trade-offs, I think it's useful to know the information. Do we ever think that the studies are as precise that we could tell you what the right number is? And you have a colleague, David Meltzer and others at the University of Chicago that spend a lot of time worrying about the methodologies behind this and worry about the heterogeneity that a service, as I mentioned earlier, is not cost effective or not. It depends the patient that you deliver it to. So when we were speaking of essential benefits, I don't think anyone envisions a world in which there's going to be a explicit rationing rule based on equality. On the other hand, I do think it is useful to know that certain types of services, at least in certain situations, an example would be proton beam therapy, is considered not very cost effective relative to alternatives, although in other situations it might be. And so I do think those types of studies are useful for organizations that are trying to either put in place incentives for individuals, physicians, and providers to use services or not. And I think it's useful for individuals to know if they were making decisions. I think it's useful if you were to change the incentives for provider organizations to know what the value, the cost effectiveness, if you will, of different services are. But I think that I would not be discouraged that if you can't find a situation in which insurance company A denied coverage for service B to person C because of some cost quality analysis, that therefore cost utility analysis is not useful.
By the way, I would make a couple observations on what you just said. One is there's this massive ideological debate that we just had in health reform, uh, but and that's kind of the frame through which we bring everything in a lot of ways around this issue. But then there's the debate. In some ways, that's masking some of the really nasty politics, which is not ideological, but it's really sort of how do you get a handle on the interest group politics of spending, and how do you could imagine that George W. Bush's the person running Medicare under George W. Bush has a lot more in common with his successor in the Obama administration than either one does with, say, a congressional committee chair who's got a wheelchair factory in his district and who has a whole different set of incentives going. And it is it's striking how many of the critiques of the methods that you and I were just talking about that are coming from Congress, what's really going on is interest group politics that's masquerading as something else, and that's one thing.
Well, I mean, I guess we're going to have a problem in the United States just in general about interest group politics, of which healthcare is certainly not immune, although I think there's a lot. The decisions in healthcare I think are particularly challenging. I seldom heard an argument, not seldom heard an argument that is just patently false in all of its rationale. I think the genuine trade-offs are more challenging than the, you know, flat out political decisions, although I wouldn't deny that there certainly are situations in which politics matter.
It's
Um,
striking how many philosophical issues are raised when you say, should Medicare have competitive bidding for wheelchairs?
yes, no, well, so that's a particularly challenging one. Although again, I think the fundamental problem with Medicare is not that we pay too much for our wheelchairs, although we might pay too much. You could debate whether we pay too much for our wheelchairs in a whole variety of ways, but that's not the fundamental problem in Medicare. I think the fundamental problem in Medicare is we have a system which um, because of the demographics, becomes exceptionally expensive. And because of the fundamental mechanisms that we have set up to pay in Medicare, don't provide incentives to capture efficiencies. There are a large number of aspects of the Medicare program that you could point to in detail that are inefficient, and some of those will have political histories behind them. But I think that the basic problem is that we have a fundamental concern that we've known about for years, which is we have a baby boom generation that is retiring. And so we have fewer workers per Medicare beneficiary, and we're blessed to have a country where there's been a lot of new medical services and technologies introduced. And we want to provide access to those services for this cohort of Medicare beneficiaries as well we should. Make sure they have access to high quality care, but the cost of doing that can be a challenge. And if we put in place strategies to try and limit the costs, which I think we both must and we are, we worry that all of those strategies have downsides, that we will inadvertently cause there to be access problems for care that we think is high value, will create unintended consequences along the system in terms of the income that providers are getting and what will have to happen to certain hospitals. It's a difficult process to manage, but I think the demographics are going to force us to strive for even greater efficiencies as we go forward.
By the way, there's one thing, and this might be a good point to end on, which I think there's another fundamental failure that we haven't talked about, which is the mismatch between the services that we want and we're going to want looking forward and just our willingness to set up a taxing structure that actually will finance Medicare at whatever level we achieve through reasonable cost control and so on. It seems to me that we just have to find a way to raise significantly more tax revenue in a way that is reasonably efficient economically, and neither party is really ready to fully engage what it's going to take to do that, because the
No,
path that we're on, even if we are reasonably disciplined about it, will require a lot more revenue. Otherwise, we'll basically kill off many things of value in federal and state governments to pay for health care.
well, so that is certainly true, although I think you could envision ways of doing this with less taxes. You know, taxes have their own drawbacks. So I think it is, I think we assume taxing is costless at our own peril. There are limits as to how much we can tax, and that's not to say we can't tax at all, but there are certainly limits to that. And so the question in part becomes, to what extent are we going to subsidize beneficiaries, and which beneficiaries are we going to subsidize? And do we care a ton if we make very rich Medicare beneficiaries pay more for access to certain types of services or access to Medicare in general? And there will be a tension, as there is across the entire country, and what's meant by very rich and what type of services are really essential, and when the services, even if they are essential, should in fact be paid for by the beneficiary as opposed to the taxpayer. So it is the case that healthcare raises a lot of emotions because of the salience around healthcare, but the same issues that pervade all of our politics around distributional issues, taxation, arise in the same way they would, just with perhaps more salience, because we're concerned with, aging as we live longer, and where we live, and who's taking care of our parents, grandparents, and soon to be us, and then eventually our children. And that trade-off gets at the core of how much we want to finance collectively and how much we want to finance individually. And I don't think there's any right answer to that.
Well, I think that's a great place to end. I'm going to stop the recording here.